This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Fellows Conference. Our speaker this morning is Muz Khawaja, one of our first-year clinical fellows. Muz came to us from Baylor, where he did his internal medicine residency. Before that, he did medical school at the University of Mississippi and did his undergraduate studies at Millsaps College. And he is going to talk to us about constriction and restriction. So, Muz, take it away.
Thank you, Dr. Williams. Thank you for the introduction, and thank you everybody for being here this morning. So without further ado, we can go ahead and get started. So, so today what I'd like to talk about, kind of brief overview, is I want to go through an interesting patient presentation just to get the ball rolling on a discussion of how to differentiate restrictive versus constrictive cardiomyopathy. We'll go through the pathophysiologies of both and then talk about multimodal approaches to diagnosis. And then we'll kind of talk at the end about management of constrictive pericarditis. So our patient is a 44-year-old gentleman who comes in an emergency room. He has a past medical history of HIV/AIDS. Last CD4 count was in the high 300s, undetectable viral load. He's got chronic hepatitis B, paroxysmal SVT. He was actually admitted about 2 years prior to this presentation for a DVT. He also had a kind of complicated course with MRSA bacteremia, had septic pulmonary emboli, and had an IVC filter placed during that time. Who's essentially coming in with chronic progressive lower extremity edema. Said that he was in his usual state of health maybe about 2 months ago and suddenly started developing some mild lower extremity edema in his ankles, progressed up to his shins. Now it's up to his hips. He's got pretty significant scrotal swelling as well. Notes that it's very uncomfortable, difficult for him to ambulate. And he used to be someone that was fairly active. He tried out some compression stockings, didn't get much relief, so he decided to come into the emergency room now. When you ask him a little bit more questions, he tells you that he's not having any orthopnea, no PND, no chest pain, no shortness of breath or dyspnea on exertion, no fevers, chills, night sweats. I mean, basically the rest of his review systems is pretty much negative. So you get a little bit more information on him. You go through his medication, social history. You see that he is on his ART. He has been compliant. He also takes Toprol XL. He says that he's been taking these medications for a while now, no issues. Social history-wise, he's a non-smoker, occasionally drinks alcohol, but no drug use. He's got stable housing. He did recently travel about 2 months ago to Houston. But other than that, nothing really pertinent, no sick contacts. He's COVID vaccinated. No family history of cardiovascular disease either. And he also has not had any surgeries in the past or recently. So when you go to see the patient, I've kind of highlighted here some of the big things on his exam. You notice that he is tachycardic to 101, but the rest of his vitals are within normal limits. He looks relatively comfortable. The kind of pertinent positives here is that he does have this kind of high-pitched early diastolic murmur that you can appreciate. He has jugular venous pulsation up to 8 centimeters. Obviously, he's got the pitting edema up to his hips bilaterally, 2+. His lungs are actually clear on exam. And then you notice on his abdomen, it's not distended, but it is a little full. He does have a positive fluid wave on his exam as well, but the rest of his exam is unremarkable. You get his labs, and you see that his CBC, his BNP are pretty much within normal limits. You do notice though on his liver function panel that he does have some evidence of liver injury, kind of more of a cholestatic pattern with an elevated direct bilirubin, total bilirubin. You notice that his INR is slightly a little bit up above normal at 1.3. They got a BNP as well in the emergency room, and it's slightly elevated as well in the 700s. His troponin is negative, his COVID is negative. They also check some infectious labs as well. They get a CD4 count, which shows that his count is okay. It's not the greatest, but it's in the high 200s. And his HIV viral load is undetectable. They also check him for Hep C and Hep B, which are also undetectable. Interestingly enough, there weren't any inflammatory markers in terms of ESR, CRP checked during this time. They got an EKG in the emergency room. It's pretty much just shows sinus tachycardia, maybe some right axis deviation, and you can see he has some new T-wave inversions and kind of V3 to V5 that he did not have on his previous EKG. But other than that, nothing else really remarkable on his EKG. So at this point, the patient gets admitted to a medicine team, and they're kind of concerned for a liver etiology, a liver process, given the liver abnormalities, the volume overload. They also were kind of maybe possibly concerned for some kind of issue going on with the patient's IVC filter. They thought maybe this is like a new thrombus, maybe that's leading to some congestion and hepatopathy and volume overload. So they got a liver ultrasound, just shows that looks like he's got some evidence of chronic liver disease and coarsened echo texture. They got a chest X-ray and CT-PE as well. I think the PE was, even though he was complaining of shortness of breath, he was tachycardic, and so I guess he has that prior history of PE, so they wanted to rule it out. So here's his chest X-ray. Here you can see, obviously, he's got an enlarged cardiac border. He does have what looks like kind of right middle and lower lobe kind of patchy airspace opacities. They read it as possibly a multifocal pneumonia. Maybe he has like a trace bilateral pleural effusions as well. They didn't call this on the chest X-ray, but if you look at the lateral view here, you can actually see that there is some evidence of almost kind of peripheral opacification of the pericardial border, which was kind of interesting to note in the lateral view. So you can kind of see it going around the edge of the pericardium there. So they proceed to get the CT-PE, and as we scroll through here, you can actually see that the CT-PE didn't show any evidence of an embolism or thrombus. However, when they get to levels of the heart, you can actually see that there is actually pretty significant biatrial enlargement in the heart, which is seemingly new. There is also, when you get to the level of the pericardium, you can see that there is some increased echogenicity in the pericardium, suggestive of kind of almost a circumferential calcification type process. So that was kind of interesting as well. So you look back at the patient's prior records, and you note that he had an echo about 2 years prior. At that time was a low normal EF, 50-55%, normal atrial sizes at that time. Normal RV size and function. So this is kind of a little bit of a drastic change in terms of what you're seeing on the CT. So you proceed to get an echo. So I'll kind of highlight some of we didn't have some of the best views, but I'll kind of go through some of the views that we do have for our patient. So here's a peristernal short axis view. Here you can see that it's got decent contractility of the LV, but you can kind of appreciate here that there seems to be this kind of abnormal motion of the intraventricular septum, kind of almost dancing in between the left ventricle and the right ventricle. There's also a small pericardial effusion there as well. So proceed to get an apical four-chamber view. So here you can actually see that, in the apical four-chamber, you have pretty significant dilation of both atria. You can see the valves are opening fine, but you can see that kind of dancing that I was kind of mentioning, where the intraventricular septum appears to be deviating left to right in between both ventricles. Here's a shot of the confluence of the hepatic vein and the IVC as they reach the right atrium, and you can see here that obviously the IVC and hepatic vein both appear distended. The IVC was not collapsible on this patient's echo exam, and you can see with the color Doppler here that actually there's a significant amount of flow away from and towards the transducer and the probe, suggestive of almost hepatic vein flow reversal. In a normal patient, when you do a pulse wave Doppler through the hepatic vein, you should see predominantly flow away from the transducer probe. But in our patient, when they did the pulse wave Doppler, you saw a significant amount of flow towards the transducer probe, suggestive of reversal of that hepatic vein flow that I was just mentioning. And here's our patient's mitral inflow E to A ratio, E velocity, A velocity. You can see that it's at 1.4. So we'll kind of talk about the significance of some of these findings a little bit later. So at this point, the patient and The primary team was a little bit pretty concerned about a constrictive versus restrictive process. The patient got a cardiac MRI, which showed pretty thickened pericardium and a prominent septal shudder and ventricular interdependence, which we'll kind of talk about what those terms mean. And obviously that those enlarged atria. So I just wanted to include those clips too, just to kind of take a look, kind of look at all the different ways that you can assess constriction versus restrictive physiology. So here, almost like a 4-chamber view, you can see that you have the enlarged atria. You can see the intraventricular septum is kind of deviating between the two ventricles, and you can kind of see it again in the short axis view as well. So at this point, obviously there was a significant amount of evidence to suggest a constrictive type picture going on here, potentially constrictive pericarditis. So the patient was taken for kind of invasive hemodynamic testing with right and left heart catheterization. But before we get to the results of what they found, I kind of want to talk about the differences between both, go through diagnosis and management. And it's important to have that distinction and understand that distinction because the management strategies can be so vastly different for both of these disease processes. So the first thing, first and foremost, what's important to understand is the normal anatomy of the pericardium. So the pericardium consists of 2 layers. There's a fibrous outer layer and a serous inner layer. The serous inner layer is the layer that's essentially composed of 2 components. It has your parietal component and your visceral component. The visceral component lines the myocardium, whereas the parietal component is lining the fibrous outer layer. And in between these 2 visceral and parietal layers is actually where you can have your pericardial, normal amount of pericardial fluid. And the normal thickness of the pericardium is somewhere roughly between 0.7 to 2 millimeters. What happens in constrictive pericarditis is essentially you have scarring and loss of that normal elasticity of the pericardial sac. It's typically a process that is chronic in nature, but you can have different phenotypic variants as well, different types of presentation that are a little bit more rapidly progressive, subacute, transient. There's also a phenomenon called occult constrictive pericarditis, which we'll kind of talk about a little bit more, but it's typically a chronic process. It takes time to develop that scarring and losing that loss of elasticity. And the diagnosis can be difficult because it can share a lot of features that we'll go through with a restrictive cardiomyopathy picture. So we'll kind of talk about that and the differences there. So big thing to understand is that in constrictive pericarditis, you're having, again, loss of that elasticity of the pericardial sac, whereas in restrictive cardiomyopathy, the way I like to think about it is you're having most commonly a non-dilated, very rigid ventricle. So you're losing that compliance of the ventricle. And what's one of the key points here is that it's going to impair diastology. So your filling of your ventricle. What actually happens in both of these processes is actually that you have ventricular filling that's occurring very early and rapidly in diastole. So what happens is when you have that rapid filling, you reach that certain fixed ventricular volume because of that fixed space, after which the ventricular volume cannot increase. So after that early rapid filling in diastole, you don't have much volume that can essentially be accommodated. And restrictive cardiomyopathy is very similar in that regard, and it can produce very similar hemodynamic changes to constrictive pericarditis. So they can both lead to diastolic heart failure, and you can have normal systolic function or near normal systolic function. But because of the differences then in terms of treatment for each of those, it's very important to try to figure out which disease process is at play for your patient. So restrictive cardiomyopathy, I won't talk about it too much, but I will mention that, obviously, as I've mentioned, it's predominance of severe diastolic dysfunction. You can have a normal EF, you can have a reduced EF, you can have a normal or thickened ventricular wall thickness. The most common etiologies that you think of is sarcoidosis and amyloidosis, so infiltrative disorders, inflammatory disorders such as those. You can have an etiology related to treatment as well. So classically with radiation therapy, chemo, XRT, for some of our malignant patients, you can have restrictive cardiomyopathy processes take place. And then interestingly, there's also a phenomenon after Plaquenil or hydroxychloroquine where you can actually have restrictive cardiomyopathy as well. And then obviously genetic and idiopathic components too. So I think the big thing to understand when you're looking at these two is what is the big difference in terms of physiology. So in constrictive processes, like I've mentioned, you have scarring of that pericardium. So you have a non-compliant pericardium with a total cardiac volume that's essentially fixed. Whereas in restriction, your compliance, pericardial compliance, is usually normal. So essentially, the other thing to remember is that you're having, in constrictive pericarditis, you have a very thick pericardium that also physiologically shields the cardiac chambers from changes in intrathoracic pressure, right? When a patient or individual takes a deep breath in and introduces a negative intrathoracic pressure, that pressure also gets transmitted to our cardiac chambers. But when you have constrictive pericarditis and you have that thick pericardium, you don't have those same, you do have some of those changes, but it's not as pronounced as it would be in a normal patient. So it's important to remember that physiologic difference as well. And then another big key point is that in constrictive processes, your interventricular septum is typically not involved in terms of the constriction or the scarring. So what happens is you have ventricular interdependence, where your interventricular septum can essentially bow or bend kind of into whichever ventricle based on the amount of volume, based on the amount of pressure that's flowing through whichever side. So it's important to understand these kind of differences. But in a restricted process, the respiration changes intrathoracic pressure should be normally transmitted to the cardiac chambers, because you're not necessarily having that pericardial barrier in a way. So this is a very key point that I wanted to make, where you're looking at a constrictive patient, and you have to try to understand the variation in inflow velocity. So you're looking at the inflow velocities across either valve, mitral valve or tricuspid valve, traditionally across the mitral valve. And what happens in constriction is your filling velocities will vary with respiration. And this is secondary to that movement of the interventricular septum. And it's important to understand that the basis for your ventricular filling velocities depends on your atrial pressure and your ventricular diastolic pressure. So what happens in patients with constrictive pericarditis is your left atrial pressure or your wedge pressure can still be somewhat influenced by breathing. So if you have a patient who takes a deep breath in, you introduce negative intrathoracic pressure, you're going to increase filling on the right side of your heart. What's going to happen is your left atrial pressure, wedge pressure, is still going to decrease, not as much as it would in a normal patient, but it should drop a little bit. However, your LV diastolic pressure is going to be more shielded by that thick pericardium. And so what happens is the LV diastolic pressure does not drop as much. And your LV filling pressure essentially depends on the left atrial pressure's ability to overcome the LV's pressure in order to cause the valve to open and to fill. And so if you don't have that favorable filling pressure gradient, it actually affects your filling velocities. And you're going to see the exact opposite in expiration. So it's important to understand that this phenomenon occurs partially because of the intraventricular septum bowing, as well as that inability of the intrathoracic pressures to be transmitted to the cardiac chambers. And so you're not able to drop your LV pressure enough to where you can allow for more proper kind of holodiastolic filling. In addition, when you have that fixed pericardial space in a constricted physiology, it forces your ventricles to accommodate each other by bowing that intraventricular septum. And so that's why you start to see that shift to the opposite ventricle. The big thing, though, to remember is that this is not always a uniform phenomenon. These velocities depend on certain circumstances and can be very variable. So the left atrial, for example, if you have a patient who has constrictive pericarditis with significantly elevated left atrial pressures, you may not see the changes in terms of inflow velocity on echo, because the pressures are so chronically high. Whereas if you have a patient who maybe has lower baseline left atrial pressures, either from being volume depleted or being earlier on in their disease process, you can appreciate some more of these changes in terms of inflow velocity changes. Another big thing also is that sometimes some of these patients can develop arrhythmias, and they may be in AFib when you're doing your inflow velocity assessment. And so it's very difficult to assess changes of the respiration because in patients with AFib, because of that variable cardiac cycle length from beat to beat. So it's not a uniform type thing, but it is an important phenomenon physiologically to understand. So again, it's important to understand the breathing changes. The breathing is can help you make drastic differentiation between these two disease processes. So respiratory variation is going to affect your ventricular filling. You're going to have dissociation of the intrathoracic and intracardiac pressure with a constricted physiology, more so as compared to restrictive. What happens with that inflow, essentially, as we talked about, is when you take a deep breath in, more blood flow on the right side of your heart, less blood flow on the left side of your heart. Your intraventricular septum is going to shift into the LV. You're going to decrease your mitral inflow because of that intraventricular septal shift, as well as your intrathoracic pressure is not being transmitted. You're not be able to drop your LV diastolic pressure as much, so your diastology is affected in that regard, and vice versa with expiration. And then we'll talk about this too as well, at looking at hepatic vein flow reversal as well, which restrictive and constrictive can be differentiated depending on when you inspire versus when you expire, when the flow reversal occurs. So we'll talk about that a little bit later. So this is kind of a nice diagram that I found that kind of kind of captures everything that we're talking about here. So with a deep breath in, you increase that pressure on the right side of the heart. You are causing more flow on the right side of the heart. And because you have that fixed pericardial space and volume, what happens is your intraventricular septum bows into the left ventricle. And so if you were to do mitral inflow velocities across the tricuspid valve and the mitral valve at the same time, if a patient was taking a deep breath in, you should see increased flow across the tricuspid valve with inspiration, and you should see a concomitant decrease of flow across the mitral valve with inspiration, and vice versa with expiration. So this is kind of a nice diagram depicting the physiology as well as the velocities. So we'll kind of switch gears a little bit and talk about etiology, symptoms, evaluation of these constrictive pericarditis patients, because for our patient, it kind of seems like that is seeming to be the picture for him. So constrictive pericarditis can happen after any pericardial disease process, and the etiology actually depends on which population you're looking at, where if you're looking at the more developed countries, you can see more post-treatment or idiopathic etiologies for constrictive pericarditis, whereas infectious etiologies are more common in developing countries. But there's also other etiologies as well, looking at connective tissue disorders. You can have malignancy-related constriction, trauma, sarcoidosis, uremia, things like that. The classic symptoms you think of is predominantly related to volume overload, and kind of more so like right-sided heart failure type symptoms. So peripheral edema. In more severe cases, you can have diffuse anasarca. But it's important when you're talking to a patient where you're suspecting constrictive pericarditis, try to focus on questioning at potential underlying causes. Do you have a history of prior malignancy? Did you get prior radiation, prior surgery or trauma? So it's important to elicit those details in his patient's history. They can tell you a lot. Big things to look out for in terms of physical exam. So in constrictive patients, you can have jugular venous pulsation. That it's the most common physical exam finding, but it's important to remember that they may not necessarily have it. If a patient has very mild or early constriction, you may not see jugular venous distension. And I also mentioned a little bit earlier, there's a phenomenon of occult constrictive pericarditis, where it's essentially a patient who has that same scarring of the pericardium, that same constrictive physiology, but because they may be volume depleted for whatever reason, you can't actually appreciate the increase in venous pressure until you actually volume resuscitate them. Constricted patients can also have pulsus paradoxus, which, as we know, is that exaggerated drop in your systolic blood pressure greater than 10 millimeters mercury during inspiration. It doesn't occur that often. It's less than 20% of patients with constriction, but you sometimes can have a constricted patients who may have a concomitant pericardial effusion with tamponade physiology, where you might see some of those things, or you might see pulsus paradoxus. Kussmaul sign, as some of you know, is the lack of the inspiratory decline in jugular venous pulsation. Can be present in constrictive pericarditis patients. Doesn't necessarily distinguish it from some other right-sided pathology, such as right-sided heart failure or tricuspid valve disease, but it can be an important clinical finding as well. The pericardial knock that sometimes you will probably get tested on boards is that high-pitched early diastolic sound that you hear, and it's actually secondary to that sudden cessation of ventricular filling. So I mentioned that in restrictive and constrictive physiology, you can have a pericardial knock, and it's because you have such rapid early diastolic filling and then sudden cessation of that filling. That sudden cessation is where you hear that's actually that high-pitched diastolic sound. And it actually occurs earlier in diastole than an S3 would, so it's important to understand when. And then other symptoms to look out for, like kind of more suggestive of severe constriction, might be peripheral edema, ascites, hepatomegaly and congestive hepatopathy, profound cachexia. These are kind of more suggestive of a severe constrictive pericarditis type picture. So if you have a patient who you're concerned for constrictive pericarditis, obviously we start with our basic initial evaluation, like we did in our patient: EKG, chest X-ray, echo. The guidelines, the European Society of Cardiology guidelines actually give all these a class 1 recommendation. Interestingly, though, on the EKG, obviously there's nothing really pathognomonic that you're looking for. You might see some non-specific ST, T-wave changes, maybe tachycardia, maybe low voltage. In more severe cases, like in our patient, when you have atrial enlargement, you're more obviously predisposed to having atrial arrhythmia, so that may be seen as well, but nothing that's like diagnostic necessarily on EKG for constriction. We saw in our patient on the chest X-ray, which is interesting. It's not always there, but you can have pericardial calcification in addition. And you saw the cardiomegaly, but the calcification is not always a telltale sign. The most patients with constrictive physiology or constrictive pericarditis will not have pericardial calcification. And its absent doesn't necessarily exclude constrictive pericarditis. But there are certain disease processes, such as tuberculosis is commonly has calcification, and it can carry some clinical implications as well. If a patient does have calcification on chest X-ray, they actually have a higher likelihood of having idiopathic pericardial disease. They're more likely to have longer duration of symptoms. They're more likely to have arrhythmias, atrial arrhythmias, and a pericardial knock on exam. And they also do actually, interestingly, have a higher perioperative mortality, but the same long-term survival. So it's kind of an interesting, almost like prognostic indicator to some extent. And obviously, it's important in this case, kind of, I wanted to highlight the use of using multiple modalities for imaging and diagnosis. So CT, cardiac MR, they all have their own benefits that we'll talk about and touch on a little bit later. And then invasive hemodynamic testing if you don't have a definitive diagnosis, with a right and left heart catheterization. The left heart cath just to kind of assess the coronaries prior to potentially a surgical intervention, and the right to kind of get assessment of the pressures. So I kind of mentioned this briefly, but just to kind of reiterate that the European Society of Cardiology guidelines on the management for 2015 for pericardial disease actually give all these a class 1 recommendation. They give a class 1 recommendation for CT and cardiac MR for assessing calcifications. Those are actually, it's much better to assess calcification with those imaging modalities as compared to echo. And obviously, if you don't have a definitive diagnosis after your initial evaluation, cardiac catheterization is indicated. So as I was reading about constriction and constrictive pericarditis, I was kind of curious, is there a diagnostic criteria? Is there any kind of uniformly accepted criteria? And I found that there's unfortunately not something that is guideline recommended, universally accepted, but there is a pretty interesting criteria that came out of Mayo that looks at these 3 components, looking at intraventricular septal shift. It looks at your medial mitral E prime velocity, as well as hepatic vein reversal ratio, which is where you take your reversal velocity when you do the pulse wave through the hepatic vein, and you divide it by the forward velocity. And if that ratio is greater than 0.79. So essentially, the presence of ventricular shift with either the second or the third criteria actually gives you a pretty sensitive and specific criteria for constrictive pericarditis, and that specificity increases even further when you have all three factors there, but the sensitivity drops off a little bit. I thought it was interesting to see, but obviously not like universally accepted. So we'll kind of dive into some of what are the features that you might see of constrictive pericarditis on different imaging modalities. So the big things when you're looking at echo on 2D, you can see it's not the best for assessing pericardial thickness, but you can sometimes appreciate that. You can see plethoric veins, atrial enlargement, that septal bounce that we talked about, where your septum bows either right or left, depending on the respiratory cycle. And then you can also have something called septal shudder that was mentioned on the cardiac MR for our patient, where you actually have a high frequency movement of the septum at the end of early diastolic filling. So it's almost like a quivering of that septum. You can see hypermobility of the atrioventricular valves, and then kind of in some cases you can see an abnormal contour between the LV and left atrial walls. So if you're looking at M modes, kind of some of the same things in terms of what's causing the changes. So you can see abrupt motion of the intraventricular septum and early diastole. So that's that shudder and that bounce. You can see if you're looking at the IVC, you may not see a systemic venous return increasing with inspiration. You can see notching of the ventricular septal tracing and early diastole, or rapid motion of that LV posterior wall. So some of these changes are related to that intraventricular septal bounce that we kind of talked about. So here's our patient's actually MO. I thought it was interesting to see that you can see some evidence of the intraventricular septum almost kind of notching there. It's difficult to see the LV posterior wall in this M mode, but you can see that there's almost some abnormal kind of rapid motion of it as well, kind of suggestive of maybe a constrictive type process. And then probably the one of the most important features on echo is the use of Doppler. So the big things that you're looking for on Doppler would be increased E velocity at your RV and LV inflow, depending on the phase of respiration that you're in. Shortened deceleration times, which we'll talk about, respiratory variation and mitral inflow velocity variation, which I mentioned a little bit earlier in terms of filling velocities, and then hepatic vein flow reversal, depending on which phase of the respiration you're in. So big things here is with the hepatic vein flow reversal, if you have a constrictive physiology and you take a deep breath in, what happens is you're going to have increased flow on the right side of your heart. The intraventricular septum is going to bow into your LV. You're going to decrease pressures on the left side, increase pressures on the right side. Whereas with expiration, if you expire, take a deep breath out, what happens is in a constrictive patient, you're going to have increased filling on the left side of the heart. And what's going to happen is that intraventricular septum is going to bow into the right ventricle, and that's going to decrease flow on the right side of your heart, and that flow is essentially going to back up into your hepatic vein and cause reversal of flow. So in constrictive patients, you should see hepatic vein flow reversal with expiration, whereas with restrictive patients, you should see it with inspiration. It's important to understand that difference. And then another key point is looking at the septal E prime to lateral E prime. In normal patients, the lateral E prime tissue Doppler velocity is actually higher than the septal velocity. But what happens in constrictive pericarditis is because you have that lateral wall is actually involved, right? You have that scarring of the pericardium that's adherent to that lateral wall. The lateral wall does not move as well. So the septal E prime velocity should be higher than your lateral E prime velocity. So these are key points to look at. And there are ways to assess whether the inflow velocity changes are significant or not. You can take this equation here at the bottom where you look at either the mitral or the tricuspid inflow. You look at the velocity with expiration, inspiration, you subtract those two and divide it, multiply by 100. If you have a change of more than 25% of the mitral inflow or 40% of the tricuspid inflow, it could be suggestive of a constrictive type picture. So it's interesting to see that there are other ways to kind of quantify this, but these are the big key features on Doppler. So as I mentioned here, the E to A ratio. So this is essentially done by taking the pulse wave through the mitral valve inflow or the tricuspid valve inflow. As we know, the E wave represents your passive blood flow from the atria into the ventricle, It depends on that pressure gradient that exists between the two chambers, and that the amplitude of the E wave, depends on the velocity and course of the flow. And it's the main factors that determine its velocity are the pressure gradient and the compliance of the left ventricle. The A wave reflects that blood flow that's generated by atrial contraction, and that depends on your atrial contractility as well as your LV compliance. A normal E to A ratio is somewhere between 0.75 and 1 to 1.5. But as you have kind of impaired ventricular relaxation in patients who have diastolic dysfunction, your E wave gets smaller and smaller because you're having reduced passive filling, because you have a stiffer ventricle, it's not relaxing very well, and that leaves a larger volume of blood for the atria to eject. So that's why your A gets a little bit bigger, E gets a little smaller. But in patients that have restrictive and constrictive physiology, what happens is you actually have, as I mentioned earlier, you have that rapid early diastolic filling. So your E wave should actually get larger. And so you should see an increased E velocity at the RV or the LV inflow because of that rapid early diastolic filling, as well as it's combined with a small ventricular volume and you have rapid recoil. So your E to A ratio should be typically high in restrictive and constrictive physiology. And I mentioned earlier that the deceleration time, right? So the deceleration time is looking at the peak from the E wave velocity, the time it takes. Essentially, this represents the time it takes to equalize the pressure between the atrium and the ventricle. And so if you have, if that time is delayed for whatever reason, if it takes longer to have diastole occur, then your deceleration time should be prolonged. However, in patients such as in constrictive and restrictive patients, your deceleration time would be shorter because, as I mentioned, you have that rapid early diastolic filling. So when you fill very rapidly and quickly, you equalize those pressures in the atria and the ventricles sooner. And so your deceleration time should be shorter in both of those disease processes. So it's suggestive of the reduced LV compliance or increased left atrial or atrial pressure. So this is just kind of depicting what you might see as you have increasing constriction or restrictive physiology. You can see your E to A ratio will actually start to climb. Your deceleration time is shorter, so important to see that there. Another thing to look at is your tissue Dopplers, right? So we use this obviously to assess diastolic function. And as we know physiologically, what happens is in diastole, your mitral annulus travels towards the apex initially, and then it travels back during diastole. And we measure that excursion with the essentially and look at the velocities, looking at the E and A prime, essentially. So it's essentially reflecting the same events that occur at the mitral inflow with the E to A. It's just in the opposite direction, essentially. And you can measure these velocities medially and laterally. And in constrictive pericarditis or constrictive physiology, what happens is your lateral E prime should be lower than your medial E prime because your lateral wall is essentially more adherent to the pericardium, and if you have scarring, if you have reduced mobility there, it makes sense that your velocity would be lower as compared to the medial. Whereas in restrictive physiology, your medial E prime should be higher than your lateral. So this is our patient's tissue Doppler here. You can see that his lateral E prime velocity was 16 centimeters per second, whereas the medial E prime was actually 19. So kind of more suggestive of a constrictive type process. Here is a depiction. I was trying to capture it on our patient's mitral valve inflow, just to kind of see if there's any evidence of respiratory variation. Obviously, we didn't have a respirometer on the patient when he had his echo done, so it's difficult to know if they're inspiring or expiring. But you can kind of see here that there is some evidence of changes at the mitral valve inflow velocity, potentially with respiration, but obviously difficult to know without a respirometer. So these are the big key things that we've kind of talked about. So in restriction and constriction, the big difference is that septal motion, right? It should be normal in a restrictive physiology, but in constrictive, it's going to change with respiration. Your E to A's are both going to be increased because of that rapid early diastolic filling. So your E velocity should be, your E to A ratio should be increased. And your deceleration time is shorter because the amount of time it takes to have equalization of those pressures is a lot shorter, and it's a lot quicker in both processes. However, what happens, what I mentioned earlier, was that mitral in-valve inflow, when you're looking at the changes in velocities with breathing, you should see that with constriction, right? Because of that phenomenon of the ventricular septum bowing, as well as the inability to transmit those intrathoracic pressure changes to your cardiac chambers. And then hepatic vein Doppler, looking at hepatic vein flow reversal, right? So with constriction, when you breathe out, you should see more hepatic vein flow reversal, because you're having the bowing of the intraventricular septum into your right ventricle. You're having that backup of fluid into the IVC and the hepatic vein, and so you should see it then, whereas inspiration should cause it in a restrictive process. And then the tissue Doppler velocities, right? So the lateral wall velocity or the lateral mitral annulus velocity should be lower in constriction as compared to restriction. So here we're just going to talk about the benefits of looking at different imaging modalities like we did in our patient. So big things to look out for on CT, obviously pericardial thickness, calcification. It's actually the most accurate technique to assess calcified tissue. Other big things you might see is dilation of the IVC, maybe deformed ventricular contours, things like that. Whereas on cardiac MR, it has some similar benefits, but you can resolve hemodynamic things a little bit better in terms of septal bounce and things of that nature. So you can see ventricular interdependence. And we saw that on our patients' cardiac MR as well. And MR is also a little bit better in terms of resolving the hemodynamic events, as well as kind of looking better at assessing pericardial inflammation, because it can kind of fine tune that pericardial myocardial border a little bit better. So you can kind of assess the inflammation a little better there. Our patient did not have late gadolinium enhancement, but that's another feature that you can sometimes see in constrictive pericarditis that on cardiac MR that can be suggestive of whether the patient's inflammation is improving or getting worse. So the last thing I'll end with is, invasive hemodynamics. So our patient was taken for the left and right heart cath, but before we get to those results, I want to talk about what you should see. So essentially with constrictive pericarditis, the big key feature is you're looking at changes with respiration, right? So what you should see on left and right heart cath, or right heart cath more so, when you have a patient with constriction at rest, you should see increased atrial pressures, significantly elevated. You should see prominent Y descent and X descent, which when you see those two kind of next to each other actually forms this classical M or W pattern. You should see equalization of the LV and RV diastolic pressures because you're in a confined space. And so that pressure, you see equalization of those pressures. And then there's also this phenomenon of the square root sign. So this actually refers to that rapid early filling in diastole. So what happens is, I'll show this on the next couple of slides, but essentially what happens is when you have that rapid filling, your LV diastolic pressure rushes up, and then there's basically impairment of filling in mid and late diastoles to where the pressure essentially just plateaus off. And so that's why you see that square root sign, which I'll show you. And then other things you might see is elevated right ventricular systolic pressures as well. So it's important to recognize some of these features. Now, with respiration, some of the big changes you might see if you're doing invasive hemodynamics is you can see changes in that rate atrial pressure. When you have failure to drop that right atrial pressure with inspiration, that's essentially Kussmaul's sign, right? You're not having that decline in that right atrial pressure. And then another thing to look at is the left atrial pressure to left ventricular pressure, or that gradient essentially, that would also vary with respiration. And I'll show that as well. And that's secondary to the phenomenon of that increased pericardial thickness, right? So when you have that shielding of the LV more so than the LA, what happens is your LV diastolic pressures cannot drop enough when you take a deep breath in. And so that gradient of the left atrium to the LV pressure gradient actually is not as strong. And so you can't have rapid filling of that ventricle. And then you'll see a phenomenon of ventricular discordance as well, which I'll kind of show here as well. So again, here's just to kind of recap the atrial pressure waveform, looking at the A wave where you see atrial contraction against an open tricuspid valve. You have your X descent, which is the atrium essentially relaxing and then filling. Your V wave where you have essentially venous return. Your atrium is tense, but the tricuspid valve is closed. And then the Y descent is where your atria will empty into your ventricles. And this is just to kind of show the LV pressures, LA pressure waveforms, as well as the aortic superimposed on each other. So here is what you might see. So this is highlighting in a constricted patient the changes in the left atrial to LV diastolic pressures, essentially. And you can see here that essentially this depends. Let me see if you guys can see my mouse here. So this area here is that gradient, that difference between the left atrial pressure and the LV diastolic pressure. That gradient, the higher that gradient is, the better your filling will be. And in this patient, you can notice that the amount of this gradient actually decreases with inspiration. And so when that patient is taking that deep breath in, your left atrial pressure is dropping to some extent, and the LV pressure is not as affected. And so that amount or that area under that curve there is not as great. And so you have impaired filling essentially. So that's that phenomenon there. This is kind of showing an example of that ventricular discordance. So essentially, as I've mentioned, that you have that fixed pericardial volume, you have to be able to accommodate both ventricles in a fixed space. So when a patient takes a deep breath in, right, increased flow on the right side of the heart, what's going to happen is that intraventricular septum is going to bow into the left side. And so your LV is going to be, the LV volume is going to be decreased to some extent. And so you're going to see a decrease in that left ventricular pressure, which you can kind of see here. If you take a look up here, you can see that the LV pressure has dropped as compared to over here with inspiration. And you can also see that the RV pressure actually increased with inspiration, right? Which makes sense. So this discordance where one is dropping and the other is increasing is what is typical or classic of constrictive physiology. Whereas in restrictive, obviously with inspiration, expiration, you are going to see changes in LV and RV pressures, but they're going to be concordant, meaning they're going to both drop or increase together. So this discordance is an important feature to look for in invasive hemodynamics. So this is kind of just depicting that again here. Let's see. And then this is just showing that the atrial pressure that you might see at the bottom, you might see in a normal patient as compared to at the top restrictive or constrictive patient. So you see at the top that you have higher atrial pressures, you have more prominent X and Y descent. You can kind of appreciate that W sign here that's coming in here. You can see that W or that M. And the Y descent's a little bit more prominent. So you have that rapid emptying and rapid relaxation. So this is just depicting that here. And this is kind of superimposed on top of the atrial pressure wave. And I remember I mentioned the square root sign a little bit earlier. So that refers to, let's see if I can pull it up here. That is this phenomenon here. So you can see here that this is that square root sign here. And it's secondary to the process where essentially you're having rapid early diastolic filling and then rapid equalization of pressure. So that's typically suggestive of a constrictive physiology. Another big thing here is you can also see equalization of the RV and LV diastolic pressures here because you have that fixed space and that fixed pericardium. So this kind of shows evidence of that as well as discordance as well. So these are some of the big features. I won't go through all of these, but in constriction and restriction, you can have prominent Y descent. In constriction, you should see kind of equal left and right sided filling pressures. The square root sign can be present in both. Pulmonary hypertension is classically a little bit more associated with restrictive cardiomyopathy. And then that change in terms of ventricular interdependence, in terms of discordance, is constriction. Whereas if it's concordant, it's more restrictive physiology. And then that gradient that you see in terms of the left atrial to left ventricular diastolic gradient in expiration, you can see that it changes with respiration and constriction, but not so much in restriction. So these are the key features to highlight on invasive hemodynamics. So what happened with our patient? Our patient went for left and right heart cath, and they saw that he, had normal coronaries, and he kind of had evidence for both. He had elevated right atrial pressures, Kussmaul sign, and then he had some, obviously prominent X and Y descent, but he also had pulmonary hypertension, which is more in line with restrictive physiology. He had square root sign, equalization of pressures. And interestingly, there was evidence of concordance as well as discordance. And so it seemed like there was evidence for both. I think the big takeaway from this is that it's not always going to be a textbook process. It's not always going to be uniform. You can't always expect it. So it's important to use that multimodal approach in terms of diagnostics to try to come to create an aggregate clinical picture. You get multiple perspectives. So last thing I'll touch on is just the management of constrictive pericarditis. So it kind of depends on the chronicity of the disease, where early stages managed more so with medications, depending on the etiology, whether it's inflammation or tuberculosis. Obviously, it can slow the progression. In terms of anti-inflammatory agents, you can use NSAIDs, colchicine, steroids, or even in severe cases, immune modulator therapy. Whereas patients who have more late-stage disease, such as our patient, where you have liver dysfunction, calcification of the pericardium, anasarca, then you kind of pursue pericardiectomy in those patients. So this is the European Society of Cardiology guidelines for management of pericarditis. So chronic constriction, they typically pursue pericardiectomy, whereas specific pericarditis pictures, you can use medical therapies. But again, chronicity is very important for these patients. And this is just a brief table in the ESC that kind of depicts the different phenotypic presentations of constriction, where you can have transient, you can even have a phenotype where you have effusive constriction, which I didn't touch on because I thought it'd get a little bit too complicated in terms of hemodynamics. But chronic constriction, they actually define as constriction persistent after 3 to 6 months, which I think our patient would probably fit that category. And the therapies are kind of listed there as well. So pericardiectomy is typically reserved for those patients. So it's a standard of treatment for patients who have pretty severe persistent symptoms, NYHA class 3 or 4. Obviously, you have to be very careful in patients who have either mild or very advanced disease, as well as certain phenotypes such as radiation-induced constriction, or if you have a systolic dysfunction or significant kidney impairment. It has a pretty significant operative mortality rate, ranging from 6 to 12%. And patients who may have end-stage constriction don't really derive as much benefit from pericardiectomy, and the operative risk is even higher. So an end-stage constrictive pericarditis patient might be someone that has cachexia, arrhythmias, heart failure, low cardiac output, maybe severe like cirrhosis or liver dysfunction. So those patients, you may not want to pursue pericardiectomy. But our patient, thankfully, was a good candidate. He did have his pericardiectomy done. He had a very extremely thick pericardium, which I'll show a picture of on the next slide. And after the procedure, he's doing great. He's got a normal EF. He had significant tricuspid regurgitation prior, but after the procedure, it's very trace. He does still have that left atrial and right atrial enlargement, which will probably be permanent, but overall, thankfully doing well. No evidence of atrial arrhythmia. So overall, he had a pretty good clinical outcome. This is his pericardium that actually on biopsy showed that he just had ischemic necrotic fibrous tissue, vascular congestion, no evidence of malignancy or infectious etiology. So I think overall it's just a case of idiopathic constrictive pericarditis, which kind of fits some of the things that we talked about. But overall, it was an interesting case. So big things I wanted to just take away from this is understanding the physiology behind this. So in the disease process with constrictive pericarditis, you're having that scarring, you're losing that elasticity of the pericardial sac, decreased pericardial compliance. Whereas in restriction, you're looking more so at the ventricle. Your ventricular compliance is more compromised. You have many similar features between both, right? You can have a high E to A ratio, shortened deceleration time, but respirophasic changes can help distinguish the two, where you can see ventricular interdependence. You can see discordance on right heart cath. You can see inflow velocity variation. You can see hepatic vein flow reversal. And it's really important to try to distinguish these two because the management of both is so drastically different. And don't shy away from using multiple modalities, right? In our patient, the invasive hemodynamics weren't necessarily a slam dunk for diagnosis of one or the other, but we had so much other clinical information. We had the CT, we had the MR. So those things together can provide a complete aggregate clinical picture for you to help kind of guide your diagnosis and management of these patients. So lastly, I just want to thank Dr. Ward for providing the case. She's been very helpful throughout this whole process. She provided the pictures. So thank you so much. Dr. Honora and Dr. Thames, they looked at my PowerPoint, helped me out with the talk. And thank you to Emory for being such a wonderful program and training program, and for all the leadership and mentorship we get here. So that's all I have.
Thank you, Muz. Very good review of a very in-depth topic. Excellent. I don't have a question. I'll just give a quick to the fellows. Something I was taught long ago, but has stuck with me over the years. You know, clinically, when you see a patient who just seems to have right heart failure, sort of well out of proportion to what you see on their echo, think constriction. Sometimes it's fairly obvious, but frequently it's not. So when you see someone who just seems to have sort of, you see them in person, you expect their echo, their RV is going to look terrible, and their RV just doesn't look so bad. That is when you should be thinking about constriction and do some of those additional testing modalities that Muz laid out for you. So a few minutes here. I'll open it up to the audience. Any other questions, comments? Dr. Smith.
Yeah, I thought that was a great talk. And it's one of the fun things about cardiology is putting all the different physiology together and thinking through the issues. Constriction is a difficult situation, and sometimes the patients have both restriction and constriction, and they may not benefit from surgery. We see that sometimes with the patients who have radiation heart disease. The other thing is that the surgery can be very difficult, and getting a complete resection can be difficult. And then sometimes the patients don't immediately get better, but they get better over time after this. We probably see a patient every couple of years who's referred for a liver transplant because of severe ascites and liver disease that turns out to be constricted pericarditis. And a final thing related to the impact of the pericardium and relationship of pericardial effusions is when you see a patient with end-stage pulmonary hypertension who has right heart failure and has a pericardial effusion, that pericardial effusion can be preventing that right ventricle from massively dilating and having severe tricuspid regurgitation. So do not tap a pericardial effusion in end-stage pulmonary hypertension. You'll have a patient die right in front of you. But the pericardium is a very an interesting subject in ventricular interdependencies as well.
Yes, sir. Thank you.
Okay. Well, again, fantastic review again of a very difficult topic, but yeah, that was great, Muz. We appreciate it. And thanks everybody for tuning in, and have a great Friday, and we'll see you next week.
The preceding program is copyrighted by Emory University.